Should I start then? Okay. So, hello guys. Today, this is a very auspicious webinar, and we will discuss a very important topic today, which is basically solving questions. And you all know that solving questions is imperative to this exam because this exam is all about question solving and not about gaining knowledge and not about just cramming of things and all that things, right? So, before going on to the actual things, we will like to introduce Dr. Sabhya here. She is basically graduated last year only, and she gave the exam in January this year. She scored 198 marks, which is a very fabulous marks, and also she was a alumni of FMG Boosters itself. So over to Dr. Sabhya, please.
So, hello everyone. My name is Dr. Sabhya Mitra. I am a recent FMG pass out. I passed this January 2026 attempt. I studied from SSR Medical College, Mauritius, and I joined FMG Boosters, I think 3 months prior to the exam. And thankfully, Dr. Onkar, Dr. Azim, and Dr. Yashank were genuinely a big boost to my entire preparation. I don't think if they were not here for my journey, I would have scored that well. So, yeah, that's about me. And about the exam and whoever is giving it, I'm wishing you all the luck and all the blessings from my end. I hope you clear it. And it's my genuine advice that under Dr. Onkar's guidance, I think all of you will ace it because the way he kept me accountable throughout the journey, the way he guided me about my question attempting strategy, about how I should approach different subjects and how I should manage them simultaneously. I think that strategy was the one that helped me the most because I think we all have the same resources. It's not about how you can get another resource or who has the best resource. It's about who uses those resources right. So I think I had the same resources as all of you might have, but how to plan it accordingly was through Dr. Onkar and Dr. Azim's guidance because I was planning and I was strategizing myself, but it wasn't until they came and helped me throughout my journey that I was actually able to make use of it as well as I should have. So thank you for that.
Thank you so much, Dr. Sabhya. And just as we speak about this webinar, it is about the question solving. So, how did you like give us a few words about did you manage to solve questions in custom modules, GTs, or even the main exam also, and what were the differences? That's
Okay. So, my resource primarily for the question bank, as advised by you, was Marrow, and that is what I kept throughout. I didn't change my question bank resource at all throughout my journey. I started solving questions, I think, not specifically just in the last 6 months that I had. I was solving questions prior, even when I was in university. I was doing that, but yes, properly solving questions and reviewing them started, I think, in August, September. So I started earlier. I wasn't doing any custom modules. I would just study a topic and I would solve it. But as you explained to me how necessary custom modules are, so what we did was we planned out 2 slots for the day. So there was slot 1 and there was slot 2. So slot 1 and slot 2 are interchangeable. So in one slot, you're supposed to keep the 4 major subjects that we have, right? We have medicine, we have obs gynac, we have PSM, and we have surgery. So one slot was these 4 subjects, and the other slot was the minor subjects. And it was 100 questions each that I kept on solving every single day until the last, I think, month. Yeah. When it was the final month, that is when we changed our strategy and we focused only on PYQs. But by that time, I had solved so many questions that when I was sitting in the final exam, I didn't feel like anything was alien to me at all. It might be like it wasn't exactly the same, definitely, but after solving so many custom modules, you get accustomed to the pattern, right? Like this is the way they can twist the question. There's one single topic. For example, if you take the topic of PPH and obs gynac, there's limited information about it. You can't really beat around the bush or whatever. But the questions can get twisted as much as possible. So how those custom modules actually helped me was with one single topic, how can you form n number of questions, and you can think of n number of questions with one single line in that textbook or in that notes or in that detailed fact interview, whatever. How can you frame it differently? So when I was sitting in the exam with that topic, I was so well versed with it that no matter how much they twist it, I would be able to attempt it. So that is how the custom modules helped me. And I think in the last month we focused on the PYQ specifically. So that was also a boost because yes, the paper pattern has changed and it is more clinical now, but it does not mean that they will change the topics. The topics will remain the same. They have some areas that they focus on always, and they still focus on that. It's just that it's more clinical now. So focusing on PYQs in my last month was not specifically for me to learn anything new. It was just to make sure that what I've learned is as strong as I could make it. So yeah, that was our strategy, and I think that is the summary of it.
Thank you so much for your kind words, Dr. Sabhya. And indeed, it was a great journey with you. So, whatever Dr. Sabhya said, guys, it is very true that solving questions is more important than actually reading notes at some point. I'm not saying that reading notes is a waste of time, but you have to understand that solving questions is more important than reading notes itself, because when you read notes, when you see the videos, right? So what we start from the 6 months of a journey is what we do is we see the videos, right? Rapid revision videos we see, which is the first read, and then we try to read the notes, and then we try to solve the questions. But what happens is that if you are reading, sorry, you are seeing the videos and then you are reading the notes, you basically don't know what weakness you have exactly, right, inside that subject. So instead of that, what you can do, what you can try to do, right, what you can try to do is you watch the videos first, then you solve the questions, then you will get to know from the analysis of those questions that you know that much and you don't know this much. So you will have actual idea that I need to focus on these topics more versus these topics. I need to focus topic in this way and not in this way, because you basically learn from your mistakes, right? That is what this whole FMG journey is. It's a learning crosscut. You learn from your mistakes, you learn from your PDs, you learn from your custom modules, you learn from everything. If you don't do questions, you will never know how much subject have you retained actually, because you see the videos and then you are like in a pseudo confidence that yes, I know the subject, but it's not like that. Unless and until you don't solve the questions, you will never know how much subject you know, right? So question solving is imperative, right? So first of all, I would like to throw the light on the fact that we all know that the passing percentage of FMG exam is less, right? But have you wondered that why it is less, right? One thing is that there is difficulty of the exam is increasing, right? But also along the same lines, students actually still follow the old pattern of learning, right? They still think that only doing PYQs, only doing rapid revision videos, only doing these videos, only doing that videos will actually help you pass the exam, right? But no, guys, the new pattern is very actually uh, different for every FMG student. So it is leaning towards clinical sides. It is leaning like NEET PG. The difficulty is now the same. There is no difference in NEET PG and FMG questions. So gone are the days where you think that FMG exam is a little bit easier than NEET PG. It's not like that. I'm sorry to say. Secondly, I would like to tell that you see that a lot of students actually have noticed maybe that you solve questions in custom models, for example, and you get a good accuracy, right? You get 70% accuracy, you get 80% accuracy. Obviously, you will be confident that yes, you might know the subject. But again, when you try to solve the TTs, right? You solve any platform TT, and then you see that you are not able to actually score, right? So you are then in a confusion that how did it happen? Like, why did I not score, right? Why did I not make up to 150, or why did I not cross 150? So, guys, there is a big difference between actually solving a simple custom module and actually giving a GT, right? The question approach in general is same, but again the strategies differ. That is where you need to understand that you need to apply different aspects to the questions, right? That is what we need to know. So keep in your mind that always solve more clinical questions, because this exam is clinically oriented now. Even subjects like anatomy, physiology, biochemistry, which are like preclinical subjects, which earlier used to be like one liner questions, just image based questions, right? These subjects too right now have clinical integration in them, right? Even though, let's say, some subjects like PSM or FMT, they still actually go on hardcore factual database questions and all those questions, right? But other than these two subjects, all other subjects mostly have clinical questions in them. If you talk about the exam, 70 to 80% questions are clinical. These are moderate type questions, and you will only be able to solve if you know the clinical concept behind it. Because nowadays, when you see the GTs, you will not be able to make out which subject is which. Because the pharmacological question can be a medicine question too. Because if you are given clinical vignette where you see that this is a case with this presenting symptoms, these clinical picture, and it is asked what is the treatment of choice. It could be a pharma question also. It could be a medicine question also, right? The same question, again, same clinical vignette, same things. If it's given a pathological slide, it becomes a pathological question. Same clinical vignette, same history, same thing. If it's asked what is the surgery of choice, it becomes a surgery question, right? Again, same clinical picture, same thing. If it's asked what is the prevalence, what is the incidence of this disease in India or in, let's say, like any other country, X country, becomes a PSM question. So you see, one clinical actual vignette is can be translated into a lot of other subjects. So this is how you should be able to think in your mind that one disease can actually be asked in other subjects also. So the link between these subjects, that is what you need to understand. Because if you see, every disease has its history and its future also. You need to know both. You need to know how this disease happened, right? That is where your physiology, pathology comes in, right? How the disease is progressing, again, that is your physiology, pathology, and your medicine part. Treatment aspect, what should be done, that is your surgery, medicine, whatever aspect it is. So you should know all the aspects of the disease. Because in the exam, if you see the recent paper also, or the previous paper also, or even the current GTs also, you see that those questions, they actually are situation based, right? Even if, let's say, there's a case of myocardial infarction, right? Now if it comes directly in the ambulance, for example, the patient has arrived in the ambulance and he's arriving to the ER, that is one situation. That is where you give a treatment. For example, you give monotherapy. But afterwards, when there is monotherapy is done, then what we do is we go to the cath lab and we do PCI. Again, the situation is changed right now, right? Then afterwards, post PCI, you have maybe complications also sometimes, right? So you will have others treatment for that. Then again, some other complications. So you will have another management for that. So you see, the disease is same, but when the situation changes of the disease, the management also changes. So that is how you need to understand in every aspect that how the situation is changing, and along that how the management is changing of the same disease. Because if you see, every clinical question, be it medicine, surgery, obs gynae, you see, any disease, for the matter of fact, it the treatment, the management changes. And the examiner is very smart actually. He will not ask you what is the treatment of choice, what is the surgical management of choice, or let's say what is the investigation of choice. That is an easy question. It is basically like he's giving you the question in a platter, right? That is not what he's doing right now. What he will ask is what is the next course of management for this disease, or let's say for this patient. If he wants to make the clinical question more lengthy, what he will do is he will not give the diagnosis also. So in 1 minute of time, you have to read the question, you have to read the options, you have to come to the diagnosis first. Then you have to think the situation of those that diagnosis, right? and then you have to find the appropriate management for that, because management includes both treatment also, sometimes it includes investigation also, right? That is where a lot of people are confused. That is where a lot of FMGs are confused, because there are always two options which are confusing. You will be confused that what should be done now. Should we go for the management itself, like treatment, or should we go for the investigation? There should be a medical management done, or there should be a surgical management done. If there is no management required, or if there is management required, right? So this is how the questions are framed nowadays. This is how you are being tested, right? Because they are not looking for students, they are looking for doctors. The day you see those exams, the questions as a doctor, that day you will be able to solve those questions. Because if you see it as a student, you will not be able to integrate it in different ways. You need to have a solid foundation for that. You need to have a good recall for your, which means you need to have a good revision, which is basically 3 4 revisions of your subject. You need to have a clear logic and understanding behind those concepts. And the most important thing, you need to actually trust all these three things, right? Your preparation basically. So if these four things are in check and you are calm also, that is where you will be able to solve those questions with ease, right? This is what actually is question solving about. This is what I had to actually tell you. So I'll just share some questions with you just to show you like what is the difference, right? We'll see a lot of like few questions. We'll see different type of questions. We'll see one liners also, maybe we'll see clinical questions also. We'll see those questions which have two options which are closed, right? And image based also. So I'll just share a screen. Okay guys, so I hope you are able to see the screen. So in front of you there are like, these are like few easy questions I would say, because if you see here, there is asking a child presents with barking cough, inspiratory stridor, which is worse at night. What is the most likely diagnosis? So the moment you see like the barking cough, right, you are able to establish the concept, and also inspiratory stridor, right? These two things, when you are able to actually get, this is basically a type of one liner question, you will see that the answer becomes what? The answer becomes group, right? Same question, the second question is, a chronic alcoholic patient is brought with confusion and ataxia. Again, chronic alcoholic, confusion, ataxia. So again, the examiner has given you the question on a platter itself, seeing that before giving glucose, right, which of the following should be administered to prevent worsening of neurological symptoms? And we all know the answer is what? Thiamine, right? We give thiamine before glucose. And again, this question, for example, a pregnant woman at 34 weeks presents with BP 170 over 110, and then proteinuria, headache, and drug of choice actually to prevent seizures is what? Again, we all know it's plain and simple magnesium sulfate, right? So these were the questions, like which were basically like easy questions. So these type of questions were asked like maybe 2 3 years ago, right? These are not the current clinically oriented questions which we actually see nowadays. These questions were used asked earlier, right? So you need to understand, you need to open your eyes, you need to burst the bubble that gone are the days where we actually see these kind of questions. I'm not saying that we don't see those questions. They are there, but they are just like 20% maybe or 10% maybe. That's it. So now in front of you, you will see some questions which are actually the current FMGE oriented questions. Now you see the first question which I have put in front of you, that a 58-year-old man with a long-standing hypertension, right, presents with sudden onset severe chest pain relating to the back, right? Examination, BP in the right arm is 180 and in left arm it is 140 over 90. ECG shows non-specific ST changes, troponin is mildly elevated. What is the most likely diagnosis? First of all, this is a very big question. Not very big, but it's a big question, right? Students actually fear, first of all, when they see a big question. They are like, मेरे से नहीं होगा भाई, बहुत बड़ा question है, छूट जाने दे, कोई दिक्कत नहीं. This is what they think, most of the students. But guys, you need to understand that the big the question, the more chances you are actually getting it right, because the examiner gives you a lot of keywords, a lot of buzzwords to actually understand what is the case about. Now you see, it had the patient has long-standing hypertension. He's old. He said sudden onset severe chest pain relating to the back. Right. So relating to the back, hypertension, BP in the right arm is 180, BP in the left arm is 140 or 90. You immediately start to guess that this may be aortic dissection, right? Because it says sudden onset severe chest pain relating to the back. Most likely, no other cardiac disease has these symptoms or these clinical picture that severe chest pain is relating to the back, basically between the scapulas. And also there is a difference in blood pressure also, right? Because of aortic dissection, there is a difference in blood pressure. As you can see, it is almost 40 systolic blood pressures, 40 systoles, right? What is the most likely diagnosis? So this is how you will get to know that answer is the aortic dissection. But let's say if I remove this part, that let's say sudden onset severe chest pain relating to the back is not there, right? Now you see, and also let's say I remove the fact that BP in the right arm is, let's say, same as BP in the left arm. Now you see, and also troponin is mildly elevated. Now the answer doesn't become aortic dissection. The answer becomes what? Acute myocardial infarction. Why? Because you remove chest pain relating to the back. It is just plain chest pain. BP in the right arm and left arm is same. Right? The clinical history is the same. Right? The patient has long-standing hypertension. But I just changed a few buzzwords and see the answer changes. Right? Now again, if I, let's say, remove the fact that troponin is absolutely normal, the patient has just chest pain and he has high BP, then again your answer changes, because the answer right now can be acute myocardial infarction also. It could be unstable angina also, right? So this is how the buzzwords, if you change in the question, you will get to know the answer becomes different, right? So this is how you need to able to differentiate in your mind. कि अगर पूछा है कि सीवेज चेस्ट पेनिट्रेटिंग टू द बैक है, एक्सक्लूड एओर्टिक डिसेक्शन. साथ में अगर दिया हुआ है राइट आर्म इज 180, लेफ्ट आर्म इज 140, then it is basically you are sure that it is aortic dissection. But let's say if it's not given and troponin is given, then it is acute myocardial infarction. Troponin is not given, then again it's not sure that it's 100% sure unstable angina. You need to do investigations, right? You will do ECG, then you will get to know if it's STEMI or non-STEMI, right? That is how you will think now. You are thinking now as a doctor, right? You are just differentiating your differential diagnosis based on what is presented in front of you. So this is how you should be able to think. This is how your perspective should be when you see this type of clinical question. Let's move on to maybe a next question. For example, this says a 32-year-old woman presents with weight gain, proximal muscle weakness, menstrual irregularities. Investigations show elevated cortisol levels, and low dose dexamethasone suppression test shows no suppression. High dose dexamethasone suppression shows suppresses cortisol. What will be the most likely diagnosis? Now, guys, we actually have seen a lot of cases where low dose dexamethasone suppression test becomes positive, and that is how you are able to diagnose that it's a Cushing syndrome, right? But this question has a little twist in it. Maybe this could come in the exam also, if you don't know, right? So it says low dose dexamethasone suppression test shows no suppression, while high dose dexamethasone suppresses cortisol. Now this cannot be Cushing syndrome. In fact, It's not even given in the options also that it's a Cushing syndrome. So what could be the likely answer to this, right? So you see step by step, right? You first of all have clarity in your mind that low dose dex no suppression, high dose there is suppression, right? So first of all you need to establish that cortisol is elevated regardless of what is the dexamethasone suppression test is there, right? Step by step we need to solve this question. So what is the interpretation? If it's suppressing with high dose, it means it's a pituitary source. It's not a exogenous source, right? So D option would be not there. Now, if you have to see other options, for example, adrenal tumor. Adrenal tumor secretes cortisol from itself, but there will be no suppression, right? Again, ectopic ACTH is there. Again, there will be no suppression. If there is, again as I said, exogenous steroid use, there will be ACTH low suppression. A very different picture, for example. So the answer becomes what? Answer becomes Cushing disease. So you see, you need to eliminate your options here. This is a type of question where you need to understand first of all what does high dose dexamethasone suppression and what does low dose dexamethasone suppression mean actually. Right? We just have a knack of just reading the fact that yes, low dose dexamethasone suppression test is equal to Cushing syndrome. What if such type of question comes in an exam where there is high dose given instead of low dose, right? This could be labeled as a hard question, but what I'm trying to say is don't just stay here in the line. Try to dig in, try to understand why it is like this and why it is not like this, because that is what the examiner is trying to ask you also. Why this is this, why this is not this. You need to go in little bit depth to understand what will be the answer to this, because the options are very close if you see, right? This is how you will able to think, this is how you able to segregate the things. Once you start segregating what is given in front of you, that is how you will be able to differentiate the options, right? एक एक करके you eliminate the options and you get to the right answer. For example, this question again. A 45-year-old male presents with abdominal pain, vomiting, distension for 2 days. On examination, he has tachycardia, fever, diffuse guarding, right? X-ray abdomen shows multiple air fluid levels and serum lactate is elevated. What is the next best step? Right? So you see that now it is asked what is the next best management. Now, a little bit time before I told you that these type of questions are asked in the exam nowadays, that what will be the next best step. Now you see the options which are very close again. It should be like whether you should continue conservative management or you should continue with CT abdomen, you should start with antibiotics, or should do emergency laparotomy, exploratory, right? So again, how this question should be approached. See the buzzwords what is given. Presence with abdominal pain, vomiting, distension for 2 days, which means it's an acute thing. And you see that it has tachycardia also, fever also, and diffuse guarding, right? Guarding means basically that it could be peritonitis also, right? And it said serum lactate is elevated. Now you should be actually able to know, you should be actually able to understand what does serum lactate is and why it is elevated and what happens if it's elevated, right? So if you think it step by step, it says obstruction, right? So if it's just obstruction, it will be conservative management. But now you see there is guarding given. Guarding means peritonitis, lactate is increased. Lactic acid and lactate is increased when there is ischemia, right? So when there is ischemia, it's a very bad situation because you have peritonitis also, you have ischemia also, which means it is a strangulated obstruction. So now in this case, you will not do conservative management, right? Because the patient might die if you just do conservative management. You will not just start antibiotics only, right? It said start antibiotics and observe. So we will not do that because it is not it is not very effective for that, right? So CT scan again, it will not show anything else apart from what we already know. So again, the answer would be emergency laparotomy. See, so think like this: the patient, let's say, has come to the ER with these symptoms. You are the posted doctor there. Let's say you are the ER surgeon, and you see all these symptoms, right? But when you see serum lactate and you see guarding, you immediately click that they should not be maintained conservatively. They should be done emergency exploratory laparotomy and not just conservative management, right? We do what is most effective, right? Again I said, situation changes, the answer changes. If lactate was normal, if multiple air fluids were not there, which means peritonitis was not present, right? It was, if it just was obstruction, normal obstruction, we could have just gone with conservative management. But now you have fever also, you have peritonitis also, you have lactate also increased. So this changes the situation, and this changes the management also. This is the type of question where you need to able to think on your feet. Right? If you are able to see this question, what will you do? Right? Same question, which was the first question there. A little bit twist in this. Now you see high fever, drooling, difficulty breathing. Child is sitting leaning forward and refuses to lie down. Inspiratory stridor is present. What is the most likely diagnosis? Now again you see there is again options croup, epiglottitis, bronchiolitis, and laryngomalacia. Again, barking cough is not given. So you will see maybe that, oh, barking cough is not given, so I should eliminate croup, right? So you are right, guys, but you need to understand that stridor is given. Stridor can be present in croup also. It could be given in epiglottitis also, right? So how do you differentiate croup and epiglottitis? Now this is a war between two options, A and B. C and D you have eliminated because you now know inspiratory stridor, fever, high fever, drooling, difficulty breathing. This is classically seen in A or B. Now it is not given that this is barking cough. But let's say you as a student don't know that, let's say croup has barking cough. Now how will you differentiate it? Right? So you need to then understand what is the classical symptoms of epiglottitis. You should also know what is the classical symptoms of croup. So generally what happens is epiglottitis have drooling. It has what you can say tripod position, which is saying leaning forward and refuses to lie down, right? These are the classical symptoms of epiglottitis, not croup, right? Even though just barking cough is not present here, doesn't mean you can just eliminate croup. You have to see other things also. This is how the first question, which was very easy, would be turned in this, and you can get confused in the exam, and an exam pressure is very high. The exam pressure is very high. We tend to do silly mistakes like this. You should be calm. You should be able to see that this is not given, this is given. So I should go with what is given, right? Okay. Now, see this question. It's a pharmacological question. A patient with organophosphate poisoning is treated with atropine but shows no improvement in muscle weakness. Which of the following drugs should be added to reverse the underlying mechanism? Right? Now you see the patient has organophosphate poisoning. Is treated with atropine, right, which is the drug of choice for this. But it shows no improvement in muscle weakness. Which of the following drugs should be added to reverse the underlying mechanism? Now, let's say we all know the answer should be digoxin, but let's say no one knows that digoxin is added, right? Let's say you forgot to read that digoxin is also given with atropine. That it's a factual data, but let's say you didn't read and you forgot to read. Now what you will do? How would you differentiate this? So what you need to understand is that diazepam, physostigmine, and neostigmine, why they should not be present and why should digoxin be the answer? So you need to now eliminate these options here. You should not go to the correct answer itself, right? Now in this question you might be thinking, digoxin शायद देते हैं कार्बाइड में देते हैं कि ओपी पॉइजनिंग में देते हैं, right? You will be confused that time. Maybe you will not be confused, maybe you will be confused. I'm talking for both sides. Let's say you're confused if it's given in organophosphate poisoning or if it's given in carbamide poisoning, right? So how will you differentiate now? So let's say if you go with the A option, diazepam. Diazepam is given to for seizures, right? It's a sedative. This patient has no improvement in muscle weakness, which means his muscles are weak. Would diazepam work there? Absolutely not. But what about physostigmine and neostigmine? Physostigmine, if you give in organophosphate poisoning, what will happen? Physostigmine is increasing the acetylcholine, right? So it will worsen the problems, right? And neostigmine, again, not useful. So even if you don't remember that pyridoxine is given along with atropine, you used your common sense and you eliminated all three options. Like, I'm sorry, and this you eliminated because you know that these will not work here. And for that, need to know what is the mechanism action of these three drugs and what they do actually in this situation. Will they worsen it or will they not worsen it? That is how you come to the actual answer. Okay. Now again, a management type question for you guys. A 28-year-old pregnant woman at 32 weeks presents with BP 160 over 110. Proteinuria, visual disturbances. She started on magnesium sulfate. After some time, she develops loss of deep tendon reflexes and respiratory depression. Again, the above question was just asking at what is the drug of choice for preeclampsia in labor mother, and that was magnesium sulfate. Now, in this question, you see a twisted question, a clinical question, that in this magnesium, magnesium sulfate is given, but after some time she develops loss of deep tendon reflexes and respiratory depression. Now, what should be done? So, again, step by step thinking you should start in your mind. क्या दिया हुआ है? Loss of deep tendon reflexes and respiratory depression could also go into cardiac arrest if the magnesium is increasing in your body. So, if you see the options, right, start diazepam and immediate delivery. Immediate delivery you cannot do because it's 32 weeks, right? I mean, you could do if the other options are not working. That's the last resort. But you have to try first the other options, right? Because we have to save the baby, right? OBS is all about how to save the baby and how to carefully deliver the baby along with no complications. So all OBS is about is how you eliminate the impending factors, impending problems, just so you will have a peaceful delivery for the mother, right? Now you see the first option: stop magnesium and observe. Is it enough, right? Because if you will stop magnesium and observe, the patient already has developed loss of deep tendon reflexes and respiratory depression, right? Which means even if you stop the magnesium from IV, for example, the magnesium which is inside our body, it's still working, right? It's still doing its job. It's still creating problems for the patient. So it will not actually do anything back for the patient. So the answer by default again becomes calcium gluconate. Why calcium gluconate? Because calcium gluconate is what doing? It is reversing magnesium activity, right? So you will in this patient give IV calcium gluconate. That is how you actually solve this question. Again, what did you do? You saw the options, you eliminated all the options, right? Again, see, now you see the few questions which I discussed seemed easy when you actually know the stuff, right? But let's say if you don't know the stuff, you will be in like hell, for example, right? Because one mistake would actually make your question into a silly mistake. So this is the depth you should actually chase in your preparation while you solve questions, while you read also, because you need to read with a perspective. You need to read with an intent that how one disease can be presented in 10 different ways. That is how you will be able to actually solve different type of questions in the same disease. Because once you get the concept right, मैं 10, 20, 50 क्वेश्चन अलग अलग टाइप के आपके सामने लाके खड़ा कर दूँ, कोई भी एंगल से, कोई भी साइड से, मतलब you will be able to solve it because you know the concept. But if you just cram the information, you just understand, you just link something superficially, you will not be able to solve a lot of questions. And you also know that the main exam, they don't follow any platform. They don't get ideas. They don't take ideas from any platform for solving questions. They have their own examiners who sit and they actually make questions for you. They test you, right? They test you as a doctor, again, not the student. So the perspective, the depth is what they actually want to see. And what is this is what they want to see. That actually can you understand this? Because this case or all the cases which I presented you before, these are actual OPD cases or actual emergency cases, which you can see when you do your internship or maybe you do JRship, whatever. Right? These are actual चीज and यही दिखता है इंडिया में और वही पूछा जाएगा आपके एग्जाम में. But in such a depth that you will not be able to understand what you do now. Right? Topics are limited. The depth is more. So you read limited, you apply infinite. Right? That is how you will be able to solve a lot of questions. Because in the main exam, even if you study whole syllabus, you will be only able to know sure short 140, 150 questions out of 300. Sure short. Other than that, all of them you have to eliminate, you have to guess. That is how. And toppers, they don't know everything. They just know how to apply good everything, and their intelligent guessing is very strong, right? And I myself has applied a lot of these aspects which I am telling you because I myself scored 221 in my exam, right? So I did not know all the questions. I did not know every question. I just knew 150 to 160 questions, sure shot. But the extra marks which I have got, it is all because of intelligent guessing, deduction, elimination, using common sense, using presence of mind. This is how you actually gain marks, right? See now, these are the same questions again. If you see, this is a question asking what is the toxin-mediated mucosal damage suspected, what is the mechanism of disease, right? In this question, you first need to know what is the diagnosis first. That is how you need to solve this question, right? Because if you don't know the diagnosis, how will you get the mechanism of disease? Correct, right? And even in this question also, let's say it's an anatomical question, for example. Patient presents with head trauma, brief loss of consciousness, lucid interval. CT scan shows hyperdense biconvex lesion. Now they are gracious enough to give you this that this CT scan shows a hyperdense biconvex lesion. Otherwise, instead of writing CT scan shows a hyperdense biconvex lesion, they can actually give you a radiological image, right, of an epidural hematoma, which is the diagnosis first. So keep actually in mind, right? Because if the diagnosis is not given, you need to make the diagnosis. You have to make the habit of making the diagnosis there itself if it's not given. Because having a diagnosis in your hand actually gives you clarity on what to do next, right? You cannot jump on again to what solving the options unless and until you don't know what is the diagnosis. What will you solve, right? How will you treat, or how do you know where it is? Because now in this question, it is asked which vessel is most likely injured. If you don't know if it's epidural hematoma, if it's subdural hematoma, if it's subarachnoid hematoma, right? Because in all these three, the vessels affected are different, right? Now in this case, what you have is you have bridging veins, middle meningeal artery, or it's internal carotid artery or visceral artery, right? So we all know it's middle meningeal artery because it's a epidural hematoma, right? But if it was, let's say, a biconvex instead of biconvex, it was a banana-shaped lesion. Let's say they have not written, they have just given you a radiological CT scan of a banana lesion, banana lesion. Yeah, the answer becomes bridging veins, right? But let's say they are gracious enough to tell you that there's a star of death appearance on the same patient. Otherwise, they have not mentioned star of death. They have given you a radiological image, and there you see the star of death. But let's say you don't know the start of death. How will you diagnose the patient? Based on the clinical history, right? But what if the clinical history is not given? This is not a very good clinical history, right? Head trauma, brief loss of consciousness, right? This is a very non-specific clinical history of a CNS patient. So again, you need to know your images also, because these are like one-liner questions also which can be asked. For example, the image is given star of death sign, and it is asked what is the diagnosis without giving any medical history. So it's a recall question. If you are able to recall, well and good. If you're not able to recall, again, guys, don't leave the question, right? You need to see what are the options given. For example, if the options were toxoplasmosis, options were, let's say, hydrocephalus, options were, let's say, anything different, for example, stroke, for example, ischemic stroke. And fourth options was subarachnoid hemorrhage. You can actually give an educated guess in these options, right? So just don't leave hope, don't leave anything, because there will always be a clue in your question. If this is not given, then it's just pure recall, then it's your luck. If you know the question, it's very well. If you don't know the question, then God bless you, right? But always look for the options. For example, if I ask you a question that there is a patient of CML, chronic myeloid leukemia, and the doctor has prescribed tyrosine kinase inhibitors for this patient. Now the options are, let's say, what is the again treatment of choice? It's sorafenib, it's tornase alpha, it's rituximab, or let's say it is bezutoxumab, for example. Right now, if you don't know what is the treatment of CML, they have told you the doctor has started tyrosine kinase inhibitors. Now, you know tyrosine kinase inhibitors, all tyrosine kinase inhibitors end with the word nib, right? So this is a very straightforward question again. But if you don't know, right? If you don't know, tyrosine kinase inhibitors end with nib or fib or maybe it's something other things. What will you do in that case, right? Considering the fact it's a very easy question because you not most of the people make mistake in this. But what I'm trying to tell you is that not most of the times you will not know the actual treatment, the actual answer to your question, short without looking at the options, right? But in these cases, what you have to do is you have to again use common sense, use elimination, and this is how you will be able to get to the answer, right? Now this question, for example, again a very tricky one. This is telling a patient on long-term steroids suddenly stops medication and presents with hypotension, weakness, vomiting. What is the cause? Right now, if let's say the student, you as a student, don't know that long-term steroid, if you stop, you get what? Adrenal crisis, for example. That is the answer to this question, which is adrenal crisis. But let's say you, as a student, don't know that stopping steroids, long-term steroids, causes adrenal crisis. Now you see the symptoms, right? You see the symptoms as hypotension, weakness, vomiting. Now you see it could be Addison disease also. It could be adrenal crisis also. So what will you do in the situation then? Now you have the situation where you don't know, like long-term steroids, they actually cause adrenal crisis. You don't know. Let's say you forgot. You're not able to recall it. You're like, "Arey, kya tha," right? This is what your situation is. So what will you do in situation now? क्या करोगे अभी इसमें? है ना? Then now you will use logic again because now you see it is saying Addison disease. Addison disease should be having something other things also, right? First of all, primary Addison disease, it's kind of autoimmune also, and it is causing the causative factors are different, right? Addison disease itself doesn't present with hypotension in the first instance itself. When Addison disease develops into an adrenal crisis, Addisonian crisis, which is the actual term here, Crisis means that the patient is crashing. You see, the patient is crashing here. Hypotension, weakness, vomiting. He's losing a lot of fluid, which means it's a crisis, right? So, if it's a crisis, then the answer should be adrenaline crisis. Let's say the patient, instead of hypotension, weakness, vomiting, the patient presented with, let's say, just the question says that he has mild, let's say, electrolyte imbalance, for example. है ना, सोडियम कम है, पोटेशियम कम है, क्लोराइड कम है, salt wasting, right? And long some steroid therapy suddenly stops medication and all that. Now your answer does not become adrenal crisis; it becomes Addison disease because the presenting complaint and presenting symptoms is different. It's not hypotension. It's the patient is not crashing. When the patient is not crashing, it becomes Addison disease, not additional crisis, right? Again, two options are very close. C and D though doesn't make sense in these questions. So this is how, even if you don't know that long-term steroids don't cause adrenal crisis, sorry, they cause adrenal crisis. This is how you will be able to actually think in your main exam that what should be done in this case. Eliminate two options, close options, think. You have 1 minute, total 1 minute for your question. If you're taking too much time, mark for review whatever you think your gut instinct says. Trust your gut instinct, for example, and then move on to the next question. And then when you have time, you come back and just start with this question. Right? That is what you do. Okay. Now let's move on to some image-based questions like how to see it. You see this question, right? Now you see in this case that it is asked what deformity and specific muscle action is lost. The options given is claw hand, ape hand, wrist drop, and benediction hand. Now again, the examiner is gracious enough to tell you the type of deformity. Like he has written for you claw hand, ape hand, wrist drop, benediction hand. Straight away you will be able to eliminate. Like doesn't look like a claw hand, doesn't look like a wrist drop like this, does not look like a benediction hand like this pope hand which is we said. So it's a ape hand. So what is written in front of ape hand? A position of thumb, opponent's policies. By default becomes your answer. But let's say the examiner tries to make this question hard. He did not write this four things: claw hand, ape hand, wrist drop, benediction hand. He did not write. He just gave you what deformity. He did not ask you. It is asking what specific muscle action is lost. Now it becomes a difficult question. Now you're confused. Addiction हो रहा है इस प्रॉब्लम इसमें, अपोजिशन हो रहा है, एक्सटेंशन प्रॉब्लम हो रहा है कि फ्लेक्शन ऑफ डिस्टल इंटरफेरेंजियल जॉइंट्स हो रहा है, क्या हो रहा है इसमें, right? And then in the exam you try to also maneuver your hand in such a way that you are able to understand what is the question asking you, right? So how do you solve this question then? Again, you need to know the muscles of your hand, what they do, what is the nerve roots, whatever nerve is supplying them, right? That is how you actually know. Because claw hand, इसमें ulnar nerve injury आती है, एप हैंड में क्या आता है, मीडियल नर्व इंजरी आती है, रिस्ट ड्रॉप क्या है, मीडियल नर्व इंजरी है, बेनेडिक्शन अगेन व्हाट, मीडियल नर्व इंजरी. अब तुम देखो बेनेडिक्शन जो डी ऑप्शन है बी ऑप्शन है, बोथ ऑफ देम में मीडियल नर्व इंजरी हो रही है, बट कहाँ हो रही है ना? लास्ट ऑप्शन क्या लिखा है, फ्लेक्शन ऑफ द डिस्टल इंटरफेरेंजियल जॉइंट्स. हो रहा है क्या फ्लेक्शन इसमें इंटरफेरेंजियल जॉइंट्स का? नहीं हो रहा है इतना. बट इफ यू सी द बी ऑप्शन, अपोजिशन ऑफ थंब, ये जो होता है, दिस इज लॉस्ट हियर, यू कैन नॉट सी दिस. So this is what the answer of the question is. It's an ape hand, and you can solve this question in such a way also that you need to link also. Maybe you have read the fact that ape hand is equal to opposition of thumb problem, and that is how you will see in this. But not wasting time in your exam that array A hand का क्या था, ये था, पर यही था क्या, दूसरा था? Because if you have rectified A hand is equal to a position of thumb problem, if you are double guessing your own studied thing, again you will tend to make silly mistakes there. So this is like, if you are able to understand, well and good. If you are able to recall and actually integrate it, like, yes, A hand is equal to a position of thumb problem, and this is what we see. This is an A hand. Again, does not matter how you reach to the answer, right? It should be fast, not fast, but actually it should be like, should not take more than 1 minute. And again, time management is like, if तुम्हारे 30 सेकंड के ऊपर जा रहा है, 1 मिनट के ऊपर जा रहा है for this question, just leave it and just go, come back later to this question, mark for review, whatever you think. Right? So this is how you can solve this question. Either you know what the hand muscles are, everything, that is the best ideal thing. Let's say you don't know, but you know that this is ape hand. Now you are thinking, you are recalling that ape hand में क्या दिक्कत था. Maybe you are able to recall it, maybe you are not able to recall it. Your luck. But let's say you're not able to recall it. Bad luck है. You see the other options. क्या है? Right? So this is how you need to try this permutation combination of your own deduction mechanisms to get to the answer actually. Right? तो वो सब उस टाइम पे याद आना चाहिए. पैनिक करोगे तो कुछ नहीं याद आएगा फिर. You just lost the question then. That is the simplest answer to it. And let's say a normal ECG question, right? Now it says 60-year-old diabetic man presents with acute chest pain leading to the left arm. ECG shows ST segment elevation in leads 1 AVL V5 and V6. Now you see also the ECG and you see the ST elevation also. Now the question is asking which coronary artery is most likely obstructed, right? So this could have been asked in a very different way also, right? This could have been asked, what is the diagnosis? So ECG questions generally, they are some type of questions. They will give you ST elevation, for example. They will ask you what is the type of myocardial infarction. Straight and basic question. You will see it's posterior, anterior, lateral, inferior, according to what you see in the ECG. Right? तुम ST elevation देखते हो कहाँ पे exactly? That is how you make the diagnosis. But now it's asking a different question. It's asking which coronary artery territory is most likely occluded. Now it becomes a difficult question. Now it is like तुमको अभी याद होना चाहिए कि इसका एनाटमी क्या था, कौन सी आर्टरी किस जगह सप्लाई करती है हार्ट को, and what MI is associated with that. Right? This is how you should now be able to think. फिर तुम विजुलाइज करोगे तुम्हारे हार्ट वेसल्स को कि हाँ एलईडी ऐसे जा रही थी, राइट कोरोनरी ऐसे जा रही थी, लेफ्ट सर्कमफ्लेक्स ऐसे जा रही थी, राइट? तो अब क्या करोगे फिर? नाउ यू हैव टू, पहली बात तो बिफोर सॉल्विंग दिस क्वेश्चन यू हैव टू मेक द डायग्नोसिस फर्स्ट, राइट? सो इसका मतलब क्या है? लीड शोइंग एसटी एलिवेशन इन 1 AVL V5 V6. आपको पता है V5 V6 मतलब इट्स अ lateral MI. Lateral wall of the ventricle is affected, right? So now you know, first of all, you know AVL V5 V6 for example, lateral side पे है, lateral side of heart पे है मतलब lateral MI है. अब तुमको बस इतना देखना है कि lateral side पे कौन सी आर्टरी सप्लाई करती है ना? Again, step by step तुम गए, you reach to the diagnosis first of all, then you know, फिर diagnosis मिल गया तो clarity मिल गई, lateral side पे है, lateral side पे कौन सी आर्टरी सप्लाई करती है हार्ट की, राइट? आरसीए तो करेगी नहीं, है ना? फिर कौन सी करेगी? Again, the correct option in this is left circumflex artery, because LED again supplies the anterior part. ऐसी आती है ना वो, लेफ्ट मेन कोरोनरी आर्टरी तो और ऊपर आ गई, एंड आरसी तो इस तरफ आ रही है राइट साइड में, तो ऑप्शन क्या बचता है? लेफ्ट सर्कमफ्लेक्स आर्टरी, राइट? सो in these questions, in these like 8 of 10 questions, I think you will have by now understood that the questions are tricky. They are not straightforward questions. 70 to 80% questions are tricky like these questions, right? If you have studied, obviously you will know the answer beforehand. I don't even need to actually explain you कि हाँ तुमको ऐसा सोचना है and then you have to get to the answer. But for the general population, I'm telling you that this is how you actually get to the answer, right? All these questions are medium level to hard questions. The exact type of questions you get in the main exams. The first three questions, which these three questions are just 10 or maybe 20% if you're lucky of the main exam. All other questions are these questions which you will get in your exam. Image based also. The general exam had a lot of image based questions. We should know your image based questions very well also. Pathological slides, macro slides, all these questions, scores, tables, TNM classifications in surgery, everything. You should do everything actually well, right? But the main point is how you reach to the answer, how you actually सोचते कैसे है, how to get to the answer itself. This is how you get to the answer, by eliminating the options, by first of all giving yourself a clarity that actually पूछा क्या गया है क्वेश्चन में, है ना? When you don't have the diagnosis, make the habit of a diagnosis, right? So if I try to summarize how to actually approach a question, let's say clinical question, because clinical question is the most common type of question right now asked in this exam, right? So first approach is read the question, see clinical picture क्या है पूरा, symptoms क्या है, history क्या है, investigation दिया है कि नहीं दिया है, option में दिया है कि नहीं दिया है, then read the options में क्या दिया हुआ है, right? You read first of all the question. So first step is read the whole question, see the symptoms, see the clinical picture, see the history, see the investigations. Make a differential diagnosis. This is the most important step. If you don't make this, you don't have a proper road to go ahead with the options. You cannot play with the options unless you don't know what is the actual differential diagnosis. So establish a differential diagnosis in your mind. Be it wrong, be it right, it's up to your trust on your own preparation. Based on the clinical symptoms, based on the clinical picture, what diagnosis you make is going to decide your answer. If it's a wrong diagnosis, wrong answer. If it's a right diagnosis, could also be a wrong answer again, right? Because it doesn't mean that if you get the right diagnosis, you get the right management also. So once you get the diagnosis, establish the situation of the diagnosis. See कि patient का हालत क्या है. Present you as a doctor, in which situation of the disease you are seeing the patient. See the situation, assess the situation, assess, then फिर decide करो मैनेजमेंट क्या करना है, इन्वेस्टिगेशन करना है, गोली देनी है, सर्जरी करनी है, डिस्चार्ज करना है, क्या करना है. दिस शुड बी योर basic approach to a clinical question. One other question is like you either know it or you don't know it. But again, intelligent guessing is required there, because sometimes when, as I'm telling you, as I told the sorafenib wala question, it's a one line question, right? So it is basically like if you don't know what is the treatment of CML, but they have given you the tyrosine kinase inhibitors दिए जा रहे हैं, and you know tyrosine kinase inhibitors is ending with NIP. So, right, here comes your answer. Never lose hope after seeing the options that मुझे ये नहीं आता है, right? Because आपको आएगा ही आएगा, because the examiner has not set it so difficult that you will not be able to guess the answer, right? Because this is an FMG exam. This is not INICT. We are not giving a competitive exam. This is a screening exam. So obviously they will set the paper in such a way that you at least know 150 questions, like not the answer, but कि हाँ तुमको पता कि हाँ ये मैंने पढ़ा हुआ है, कुछ तो पढ़ा हुआ है इसके बारे में, कुछ तो सर ने बताया था, मैम ने बताया था, और ये मुझे पता है. right? So 150 questions you will always know in your exam that हाँ ये मैंने पढ़ा है, ये मुझे पता भी हो सकता है शायद अगर मैं थोड़ा सा शांत दिमाग लगाऊं तो, right? If I keep my temperament cool, if I keep my calm, and I actually look the question with pure logic, not emotions, I'll just crack the question itself. Sometimes question tells you the answer, sometimes options tell you the answer, right? Sometimes ऐसा भी होता है कि तुमने अगर प्रीवियसली कोई क्वेश्चन सॉल्व किया होगा, उसका मिलता जुलता क्वेश्चन तुमको आगे मिल सकता है, मे बी इफ यू आर लकी, है ना? तो तुम ऐसा कर सकते हो कि फिर अरे हाँ यहाँ पे ये किया था तो शायद यहाँ पे फिर ये आएगा, होता है फिर, देन योर बोथ आंसर बिकम्स करेक्ट. दिस ऑल्सो हैपेंस. एंड इमेज बेस्ड क्वेश्चंस अगेन, जैसे मैंने बताया, ईसीजी क्वेश्चन और फॉर द मैटर ऑफ फैक्ट इवन दिस क्वेश्चन वुड बी आस्क्ड इन अ वेरी डिफरेंट वे, है ना? इसका जैसे कि अगर ऐसा भी पूछ सकते हैं कि ये नहीं पूछ के पूछेंगे कौन सा nerve injured है इसमें, which nerve is injured in this, it can also be asked, right? So understand the perspective, understand the disease in 10 different perspectives, understand the disease history, future, progression, everything. You should know the disease and what to do for the disease, है ना? क्योंकि एक डिजीज को कैसे भी पूछ सकते हैं ये लोग, and that is not predictable, but you have to be prepared for everything, है ना? Prepare for the worst so that you can score the best. That is what you need to understand. So this is all I have to say about question approaches and how to in general solve questions, how to in general get to the answer if you're not able to guess what is the answer, right? It's just not that it's your sole memory which is actually responsible for getting to the answer. It is your question solving skills in general. And first of all, question solving skills always only work when you are calm. If you are not calm, you will not be able to actually think in the right direction, in the right mind, and you will be making silly mistakes in the main exam. एंड फिर आपको ऐसा लगेगा कि अरे मुझे जीटीज में अच्छे आते थे, 180 190 आते थे मेन एग्जाम में, बट पास नहीं हो पाया, मतलब ऐसा. दिस इज द एक्चुअल रियलिटी, लाइक ऐसा क्यों होता है? दिस इज द सोल रीजन. इफ यू आर नॉट एबल टू हैंडल द एग्जाम एनवायरनमेंट, if under pressure you change answers too much, if you are unfamiliar with the language, then it becomes a problem. Language also is very important because English is not just for English readers, it is for us also. You should know the jargons, you should know the हाई-फाई इंग्लिश जो होती है वो आपको पता होनी चाहिए, बिकॉज वो पूछी जाती है एग्जाम में. एटलीस्ट जो मेडिकल रिलेटेड होती है ना, इफ इट says incremental decremental response, you should know what incremental decremental means, right? If let's say it says the disease has been in remission or the disease has relapsed, दोनों का मतलब पता होना चाहिए. The disease is going anterograde or disease is going retrograde, दोनों का मतलब पता होना चाहिए. Otherwise, how will you get the answer correct, right? Whatever is presented to you in a question, you should know the meaning of all those words. That is how you will be able to understand the question first of all. If you know the English, you know the meaning of words. अगर नहीं पता है तो फिर question नहीं समझेगा, ना? Simple सी बात है. So that is what I have to say about all these things, and we can just wrap up this meeting now. And I hope you actually enjoyed the meeting and you understood what actually should be done, and can give a thumbs up also if you like this webinar. And thank you so much again for being patient with me and being actually in this important webinar, which is it's a very crux of your preparation, which is question solving. A very underrated topic, a very underrated, I would say, thing actually to master in your preparation, because everyone is running after resources. Everyone is running after crisp resources, crisp this, crisp that. No one is actually trying to solve good quality questions, है ना? Good quality questions होना बहुत जरूरी है guys. Telegram के questions are not good quality questions. You need a good quality edtech platform. You need a good quality mentor. You need a good quality videos. Everything you need good quality actually to understand the beauty of this subject, which is called medicine, right? If you don't understand, you are just being a sorrow donkey, I would say, who is just doing uh, work and not able to understand anything, right? So don't be a sorrow donkey. Be a smart guy, a smart girl who's actually understanding that end of the day I have to solve questions in the exam, so I need to know how to solve the questions, right? So yeah, just all the best, and I wish from my bottom of my heart that all of you would pass this exam with flying colors.